Welcome to another edition of Inside Miami Medicine. I'm your host, Dr. Henry Ford, the Dean and Chief Academic Officer of the University of Miami Leonard M. Miller School of Medicine. Today, we're exploring exciting advances in headache and migraine research, including neuromodulation devices, a first-of-its-kind non-oral treatment. We'll also explore other innovations that our teams are using to relieve and improve patient care. To discuss these novel approaches to the treatment of migraine, headache, and more, I welcome to the studio Dr. Teshamae Monteith, Professor of Clinical Neurology and Chief of our Headache Division at the University of Miami Miller School of Medicine. Dr. Monteith, welcome.
Thank you for having me, and thank you for focusing on this important area.
Well, before we delve into this very important area, as you alluded to, tell us a little bit about your journey and how you became the chief of the division.
Yeah, so a very interesting journey. I'm actually a native of South Florida. I was born in New York, but I grew up here, did my schooling here, went to Florida International University as an undergraduate, and then I was a medical school student here at University of Miami, and figured neurology at some point. And it's funny because reflecting my clerkship director, I thought I was interested in interventional pain at the time. My clerkship director, Dr. Gordon, said, "Tisha, you're going into headache." I was like, he's wrong. He's so out of it, out of touch. And then I went to New York, NYU, and there was a lot of opportunity to learn about headache disorders. I spent time in the VA, and of course, that was a time when a lot of the veterans were returning with post-traumatic headache and worsening migraine due to some of the wars in Iraq and Afghanistan. And that was very meaningful. This was also a time post 9/11 when there was a lot of stress and a lot of different systemic disorders associated with that event, but also headache was an issue. So there were a lot of things, including it was just very common and an opportunity to really improve quality of life with even the existing treatments back then. And so what I loved about headache was the public health relevance, the interesting science in headache and the emerging headache as an emerging field, and the opportunity to make a real impact. And so that was as a resident. I then went on to do a fellowship at Thomas Jefferson, probably one of the largest programs, multidisciplinary program. And I was very excited to get that exposure with some of the leaders in the field. Then I realized, wow, I really like headache research. So I then decided to go to San Francisco for 2 years, and I did a 2-year additional fellowship, which is very unusual, but with Peter Goadsby, who is probably undoubtedly the probably foremost leader in headache medicine. And a lot of the therapeutics that we use today is based on some of his early research. And so after that, I needed a job. After all these years of fellowship, at some point you have to get a job. And I looked at different places. And really, at the time, Ralph Sacco had the best opportunity for me to come back home. It wasn't something that I thought I was going to do. I thought Florida would be something for when I'm old. Old people retire in Florida. And really, it was just a very exciting opportunity to work really right under Dr. Sacco with his Northern Manhattan study, looking at migraine and vascular risk factors and imaging findings.
That's fantastic. That's a formidable amount of training. No wonder you're the chief. So for the audience, please define what you mean by headache disorders. I mean, how many different types are there? We know we hear about migraine. Is that the only form? Just please talk about this.
Yeah.
And how is it that there's a whole specialty on headache, migraine? Please.
Yeah. So that's a wonderful question. So headache is the third. Well, migraine alone is the most prevalent disorder worldwide. Dental cavities is the first, and actually tension type headache is number 2. So a headache, and then migraine is number 3 in terms of prevalence. So a lot of people experience this problem. as headache specialists, a lot of what we focus on are the primary headache disorders and making sure people don't have secondary types. So when we look at the primary headache disorders, we're looking at tension type headache, which is often not what's seen in our neurology clinics. It's oftentimes a migraine, and there are different subtypes of migraine. The trigeminal autonomic cephalgias, which includes cluster headache, which are more rare disorders, but we do see them. And then there are this other headache syndromes that are probably less known to most people and can be extremely disabling. And these can include things like new daily persistent headache. We've seen that with patients that have had vaccinations. And unfortunately, these are, thank God, not a lot of people, but in our clinics, some that then go on to have persistent headaches after a vaccine that just doesn't go away. Can also be associated with certain infections like EBV. So that's the new daily persistent headache. There are other things, headache associated with sexual activity. Of course, you have to worry about aneurysms and other things, vasospasm, but there's a primary form of sex-related headache as well. So there are multiple types of primary headache disorders. That's a lot of what we treat. Most of it is migraine. Most of it is disabling types of migraine. In our clinic as headache specialists, we see a lot of people with chronic migraine, which is people that have headache half the month or more for at least 3 months. 8 of those days fit the features of migraine, which tend to be very disabling. Many of our patients have headache all the time, and they're walking around, they're doing their jobs. You would never know that they're suffering because it's somewhat an invisible disorder. You can't really see it just by looking at a person, and you certainly can't see it on a X-ray or MRI.
I don't know if I'm more confused after hearing all these different types of headache disorders, or I never knew it was that complicated. So what exactly triggers a migraine?
Yeah.
You say that's the most disabling and the most common among.
Yeah, so migraine is the most common. First of all, we should recognize it as most of the time an inherited disorder. It's a chronic disorder. So migraine is a brain disorder that's there, but there are episodic manifestations of migraine. And there are, because we said...
Remind me, is migraine in the inherited versus...
It's inherited.
Primary? Okay.
It's a primary disorder, and it's often inherited. Many people don't recognize the inheritance because people don't always talk about their migraine. They think it's just a headache. Only half of the people that have migraine have the diagnosis of migraine. So the other half think it's just a headache. They take something and they don't necessarily get that. Even if they go and talk to their primary care doctors, migraine is grossly underdiagnosed, which is a big problem.
Tell me, is there a gene associated with that?
There are genes associated with it. The classic Mendelian genes are these genes, the hemiplegic migraine. So there are 3 or now considered 4 types. And these are people that have what looks like hemiparesis associated with their migraine attacks, stroke-like symptoms with their migraine attacks. Those are more rare types of migraine. The majority of people have what we call risk loci or multiple risk loci, and now there's over 123 risk loci associated. So we don't really have a genetic panel for more common types of migraine. We do know the specific genes for the more rare types.
So if a family member has it, it's plausible that if an offspring starts to develop the symptoms, that's an inherited disorder. And so does that have specific implications for how it should be treated?
Yeah.
Or diagnosed?
Yeah.
Let's talk about the diagnosis.
Yeah, so we should talk about the diagnosis because I think people understand migraine intuitively, but yet it's still so underdiagnosed. So we should talk about the diagnosis.
Let me confess, I always thought migraine is a headache that you just can't treat.
Yeah, well, I think that it can be a difficult and refractory headache. And we do have some people in our clinics that, despite even high quality treatment, they have difficulty in responding to treatments. But that is the minority. Those are people hang out in headache clinics, not typically what we see in the general population or even primary care clinics. And so
How do you diagnose?
getting the diagnosis is important. The best way we think about the diagnosis is based on the classification criteria. even though there are many other aspects to migraine than what's in the classification. But the classification is important because we need a common language to think about migraine, especially for clinical trials and public health interventions. So when we think about migraine, we think about it being a recurrent disorder.
That's triggered by what?
Well, we'll talk about the triggers, but it's a recurrent disorder that's often associated with moderate to severe pain that's usually lasting between 4 to 72 hours when untreated. It's pounding, it's throbbing, it's pulsating. It's often on one side of the head. And it has associated features with it, such as movement sensitivity. So regular walking can aggravate the pain. There may be sensitivity to light, sound. So you can imagine like screen time and things like that. Sensitivity to light, sound, nausea, vomiting, and there, you need to have a few of these and a few of these to meet the criteria. But if you have a collection of those symptoms, you likely have migraine.
That's very disabling. How you can't function.
It's and it's a huge, huge problem. And part of the issue is we say it's unilateral. There's light sensitivity. Not everyone has to have unilateral for it. So there are people that think that it has to be unilateral for it to be a migraine. That's not true. It can be throbbing, but it doesn't always have to be throbbing. Light sensitivity can be subtle. Sound sensitivity can be subtle. Nausea can be subtle. So if you don't have very prominent symptoms, it's easy to miss the diagnosis. So that's important to recognize, because migraine, even within an individual, can vary in intensity, in severity. So we talk a lot about the pain, but it's important to think of migraine as more than just a headache. There are many symptoms associated with migraine that can almost even be equally disabling. Some of that might be cognitive impairment, word finding difficulties, fatigue. Those are common other symptoms associated with processing problems. So there can be even a delay in understanding what someone is saying, or even ability to produce language. So that is important features. These non-pain features are becoming more important to think about when we think about treating patients, not just the headache, because sometimes we can get rid of the headache, but sometimes these non-pain features can linger. They can be present in between attacks. So you have an attack of migraine, it takes something, goes away, but in between this interictal phase, people may also have low levels of light sensitivity, sound sensitivity, irritability, fatigue. That could also be a problem. So it's important to think of it as a chronic disorder and not just define it by its attacks, and not just to define it by headache. And we can also talk about triggers.
So yeah, it's excellent. So to summarize, so you make the diagnosis on the basis of a symptom complex. There isn't a blood test that you're going to do to say, it comes back. Yeah, you're positive for migraine. No.
Right.
Okay. So tell us then about the triggers.
Yeah.
And then we can get into treatment.
Yeah. So triggers are really important, but also very hard, because triggers can vary within an individual, and amongst a panel of triggers, not everyone's going to have that same trigger. So very common triggers, probably the number one trigger that people identify is stress as being a cause of migraine. Now, it can be complicated because when people are having migraine, they may be more vulnerable to stress. So it may not be the stress, it may be the inherent vulnerability to stress. And that's a theme with other triggers as well. It's hard when we do diary studies to really identify the link between stressor and a migraine attack. Much easier to identify stress letdown. Okay, I've finished my meeting with the dean and I did well, no migraine, but now an hour later, I get this really severe migraine attack. That's the stress letdown phase. And so that that is something that biologically we can seem to connect that more than the stress itself, which for many reasons. So there's stress, changes in sleep, and that could be.
So you think there might be some protective effect because of hormonal release? Is it the epinephrine, the excitement about, or the anxiety associated with meeting, and then after that, you're back to your regular.
Yeah.
Okay.
So migraine brain likes regularity, regardless of what that is. So hormonal fluctuations, which I'm glad you brought that up, is a very important and very prominent trigger for migraine. So that fluctuation can be perimenstrual, around your menstruation time. it can be perimenopausal or around that transition time. That fluctuation is very triggering to the migraine brain that likes stability. And that's also the case for stress. That's also the cases for changes in sleep and shift work. We do have nurses here. We have residents and fellows that work and they have shift work. And that can be very disturbing when they have to switch. I have know one patient that works in the emergency room, and that night and then switching to day, that switching, because we know that migraine is associated with homeostatic mechanisms, and that includes circadian rhythms and biologic rhythms. And when we kind of shift back and forth, it's harder for the migraine brain to adjust to that shifting. So that also includes, because we said the homeostatic mechanisms, things like food. So fasting can also be triggering. So these shifting in regular routine behaviors can be very problematic to the migraine brain.
So if we're going to let the audience have a takeaway message here, let me try to begin to paraphrase what you would want to say. Is try to be consistent, try to avoid stress, and what else?
Yeah. So avoiding stress.
Or should you be studying your own triggers so that you know the things that may provoke this migraine? In this way, you will be more prone, or you'll be less prone to developing.
I think awareness is really important because it can vary again with individuals. There are many people that can do all-nighters and never get a migraine, and they have it with other things. And so it's important to know your own personal triggers if possible, but it's not always easy to identify. Hormonal is an important one to try and identify if you're a woman. And so, yeah, if you're able to identify triggers, absolutely. Don't go too crazy on triggers. It can be very restricting to do the trigger avoidance thing. So we want to make sure that we're holistic and not restricting too much, avoiding stress. What does that mean? Not going to school, and not getting married, not walking out of your house, so
Yeah.
I think having behaviors and mechanisms in place to be able to cope, increase your stress tolerance, and your awareness. I think that's more to have those protective resilience mechanisms in place is important. Of course, getting good therapies are going to be fundamental.
And then this is a good segue. So awareness is really the critical element here in terms of migraine avoidance or prevention. Now, let's talk a little bit about the treatments. Now, you've done some groundbreaking research on the role of neuropeptides in hormones in migraine. So tell us a little bit about that work.
There are now these newer drugs that are available that target CGRP, calcitonin gene-related peptide, and these have been groundbreaking therapies.
Tell us about this. Why is this particular peptide important?
Yeah, so what's important about CGRP is when there's a migraine attack, there are numerous mediators that are released, and that includes neuropeptides, that includes glutamate, that includes cytokines, other things that are released. But calcitonin gene-related peptide is a signaling molecule that signals migraine pain. It's important for other things too.
It makes you have pain, or
it makes you have a pain.
Okay.
And so it's released during an acute migraine attack. It does other important things in the body too. It's the most potent vasodilator in the body. It's also involved in allergy. So it is important for other things too. But, and there's been a whole lot of work leading up to the first studies that then got FDA approval to target CGRP. And this were the monoclonal.
So Godsby measured the blood level of CGRP patients when they were having a migraine.
Yeah,
and it's elevated.
They were elevated.
Got it.
And there's also work that showed that treating with sumatriptan, which is migraine abortive therapy, lowers CGRP. So during acute migraine attack, it goes up, treatment goes down, headache also follows that pattern. And then there were some people that did experiments, they gave CGRP intravenously, it triggered migraine attacks. So clearly we saw that there was a relationship with CGRP and migraine pain. Also, CGRP is persistently elevated in people that have that chronic migraine. So,
And how do you stop CGRP?
Yeah,
Or do you block its effect?
Yeah, so perfect question. That's work that had been done. Some of the work that I've been a collaborator on is looking at some of the GPANs, because we talked about the MABs blocking CGRP.
That's what MABs, for those who don't know, it's monoclonal antibodies.
Yeah, but we can also use small molecule antagonists to block CGRP receptors. And so there are a number of receptor blockers that are available. We call them the GPANs. And
What does that stand?
the GPANs is it's these small molecule receptor antagonists. Yeah, and so so this class of new therapeutics, we have one clinical trial ongoing now. Our one clinical trial is looking at patients that are on Botox, on a botulinum toxin A, which is FDA approved for treatment of chronic migraine, and if they still have 8 to 23 migraine days per month, we add on atogepant, which is one of the GPANs, to see if combination therapy works better than the botulinum toxin alone. So we're happy to be part of a multi-center study looking at the combination therapy, and those results will be out soon.
So you can take it intravenously, you can take it orally, but are there other ways of taking this antagonist?
Yeah. So intravenously would be the monoclonal antibodies, subcutaneous injection monoclonal antibodies. But when we talk about the GPANs, we talked about orally for the atogepant.
Right.
We also now have a new molecule, vegezapant, which is the first intranasal spray.
So it's nasal spray.
It's a nasal spray for acute treatment of migraine. And
how quickly does it work?
It works very fast, as patients were able to have reduced disability in 30 minutes. It met its co-primary endpoints, which is pain freedom, separating from placebo in 2 hours for pain freedom, as well as most bothersome symptoms. And so that was based on the original studies. I was involved in a post hoc analysis of an open label study looking at, in the cohort of patients, comparing those, which was about 1/3 with anxiety and depression, with those that did not have, just to look at tolerability and safety. We didn't talk about comorbidity burden, but anxiety and depression are leading comorbidities in migraine clinics, and they have a bidirectional relationship. Many of these patients are on other medications, so we wanted to make sure that this was a safe option in this group of patients. And we found that there were no differences when comparing the tolerability and safety in those with anxiety and depression and those without.
That's fantastic. So it sounds like we do have some modalities that can alleviate the suffering from migraine. What else is on the horizon? You mentioned neuromodulation. What is that? And which population should undergo the monoclonal antibody treatment, the GPANs versus neuromodulation?
I'm so excited to hear you talk my lingo.
I'm learning.
We need to have you come to our division. So neuromodulation is a really exciting area in headache disorders and in pain. They generally work by targeting peripheral nerves, which then allow access to central mechanisms. And there are different peripheral nerves that are involved. There is the external trigeminal stimulator, and there are now 2 of them that are on the market. And so those work by stimulating the trigeminal nerve. And there have been PET imaging studies and functional MRI imaging studies showing that they do make changes in the brain. And so we know that we are targeting brain mechanisms by access to the peripheral nerves. There's also a vagal nerve stimulator, and that stimulates the cervical portion of the vagal nerve, and that has approvals for treatment of migraine, treatment of cluster headache, and other trigeminal autonomic cephalgias.
Is this a one-time treatment, or do you have to come back for nerve stimulation?
Yeah, so these are prescriptions, largely prescriptions that you give to patients, and then they have them or they rent them. And they can be used for acute treatment. They can also be used repetitively for prevention.
And which patients patient selection for this form of treatment? Tell us about it.
Yeah. So,
You gonna give me a spray, or you gonna
yeah,
give me
yeah,
neuromodulation?
yeah. There are different devices as mentioned. So some of this is going to be based on what patients may prefer. There's a remote electrical neuromodulation device called REN that's available for patients too. So if patients want to wear something underneath their blouse and it's they're not really able to, show when they're at work, they can use a treatment, and it's probably the one that is most discreet. And so, depending on patient preference, might be important. If a patient has what we call allodynia, skin sensitivity, you may not want to put a device on their forehead, for example. Cost is a barrier. We do have to talk about cost because many of, I would say almost all of the insurers do not pay for the neuromodulation devices. And so financial status is one of the things that we do think about when we think about who we're going to give a device to. If patients are from the VA, they may be able to get some of the devices paid for. So access is still a major barrier for patients. But when we think about who we may give that to, a patient that doesn't want to be on medications, maybe this is a patient that is on many medications for other medical conditions or prefers more of a natural approach, that might be an option for a patient. If a patient's already overusing analgesics, you may want to introduce a device so they're not having to use more of those acute treatments. So that might be a pregnant patient or a patient that's lactating is maybe another option.
So tell us a little bit about your predictions for the future. I mean, where are we going with headache disorders? Do we see the prevalence going to continue to increase? Are there newer ways that we're going to be able to deal with this vexing problem? And, of course, everybody's talking about artificial intelligence, machine learning. Is there a role for these technologies to play
Yeah.
in helping us?
So it's wonderful questions. So about 1 billion people across the globe have migraine alone, and there are, as mentioned, other headache disorders. What we find that the prevalence seems to be somewhat stable, but that they're more disabling. Migraine tends to be more disabling than in the past, and then we're finding in other countries that tended to report or underreport migraine, that migraine is increasing in other countries that are maybe low income, medium to low income. And so it's becoming, it is already a global problem. When we think about the United Nations Sustainable Goals, migraine is the perfect disorder to think about improving well-being and thinking about chronic disease. It's the perfect model for that. We do need to think about artificial intelligence. It's here. Let's not fight it. Let's embrace it. We get a lot of messages communicating with our patients, and we need to be able to think about how can we best reduce, I would say, administrative burdens when, caring for a patient, so that we can provide the best quality of care for our patients and also support our providers. And I think artificial intelligence is going to be really one key way to do that. When we talk about a huge wait list, we need to talk about how artificial intelligence can be incorporated to maybe identify patients that maybe need to be expedited and be seen versus maybe be seen in primary care clinics. And then there's the opportunities for virtual digital learning strategies. We're all on Zoom these days. And how can we better educate our primary care doctors or community partners to treat migraine when it really, some of these, the majority of it should be treated in the community.
Fantastic. Well, Dr. Monteith, let me express my sincere thanks, not only for the fact that you're the chief of our division headaches in general, but also for your expertise in that domain. I mean, I learned so much about something that I thought was just rather pedestrian, like a headache. But clearly it's a significant discipline, and you're looking at a problem that is affecting a large segment of the U.S. population. So thank you for your expertise. Thank you for your passion, because that's a difference maker. And I hope that we'll be able to I'll host you again to hear about progress in the treatment of headache disorders. And thank you for joining us for this fascinating episode of Inside Your Miami Medicine. Until next time, I'm your host, Henri Ford.